Welcome to this third lecture on the head and neck anatomy, where in this particular lecture, we're going to look at anatomy of the orbit, as well as anatomy of the eye and the visual pathway. I will give this lecture in two parts, actually. The first part of it will focus on the orbit itself. And for this, we are going to look at the following: the bones that form the orbital walls. The orbital walls can be considered as a roof, floor, medial wall, lateral wall, and the margin. Also, the fissures and foramina that are within the orbit. We'll also look at the contents of them. There's something called the tendinous ring. Within the orbit, we're going to look at the structure of the tendinous ring. Then we'll talk about the fascial layers of the orbit and the organization of the orbital fat. We'll also look at the extraocular muscles. These are the muscles that move the eye, so we'll also look at their effect on the eye. And lastly, we look at the neurovascular structures within the orbit. So that's basically the first part of the lecture. The second part of the lecture focuses more on the eyeball itself, the structure of the eyeball. Then it also focuses on the visual pathway, and I'll tell you more about that. So let's focus on this first part. We'll begin with the orbital walls. Maybe before we look at the orbital walls, it's good to define what the orbit is. So the orbit are these paired skeletal cavities that are in front of the cranium. And we know that they house the eyes and therefore also protect them. In terms of their shape, they are quadrilateral, which means there are four sides, but they're also pyramidal, which means there's a base which is broader and an apex that is narrower. The base is actually anterior, and this is the base. The base of the orbit is termed the orbital margin or the orbital rim. The apex of the orbit is this region here, where a number of structures enter or leave the orbit. Generally, the apex is posteromedial, which means not directly so posterior with respect to the base, but posteromedial. That tells you a lot about the orientation of the medial wall and the orientation of the lateral wall of the orbit. So this shows you the orbital margin still, and that's the orbital apex. So the medial walls of the orbit are almost parallel to each other, and the lateral walls of the orbit, when you converge them, they almost make about 90 degrees posteriorly. Now we know that the orbits contain the eyeballs, but the eyeballs are not the only content of the orbit. As a matter of fact, the eyeball only occupies 1/5 of the total orbital volume. Look at this image here. So this is the eyeball labeled 4 with its wall there, label 5. And this is the orbit. Now you can see that only this part of the eyeball is within the orbit, and that occupies about 1/5 of the total orbital volume. While in this image, we can also appreciate that there's some part of the eyeball or the globe that are actually extraorbital, and the anterior parts of the globe are actually extraorbital. That has some implications. It is a risk, yes, for injury, but it increases the possibility of having a wider field of view. So this protrusion of the eyes slightly outside the orbital sockets are important to increase the size of the visual field. Other than the globe, there are many other contents of the orbit, and we can just name them. So we have fat tissue. We have a lot of neurovascular structures, so arteries, veins, nerves. The lacrimal glands are also within the orbit, and extraocular muscles, when we'll be talking more about them. So this image shows you various structures which are found within the orbit. Even this also shows you various structures from the orbit and also showing you that slight protrusion of the eye beyond the orbital socket to increase the visual field. In terms of the walls of the orbit, we can describe the orbital walls, as I mentioned earlier, in terms of the roof, the medial wall, the lateral wall, and the floor. And so I want us to look at these orbital walls. So this image shows you the orbit again. This is the rim. So this will be the medial wall. This will be the roof. This is the lateral wall, and this is the floor. Let's begin by talking about the orbital rim. The orbital rim is the anterior circular margin of the orbit, and as I've told you, it forms the base of the orbit. It's the base of the pyramid. There are three major bones that form the orbital margin, and they almost take about a third. It's just an approximate. So we have the frontal bone up there. We have the maxilla inferomedially and the zygomatic bone inferolaterally. Those are the bones that form the orbital margin. How about the orbital apex? So the orbital apex is the posterior confluence of the orbital walls, medial wall, lateral wall, roof, and floor all join around that region. So this is the region of the orbital apex. At the orbital apex, we have the optic canal, which is where the pointer is right now, and also the superior orbital fissure, which is this one. The inferior orbital fissure is not quite within the apex because this is the inferior orbital fissure, but the superior orbital fissure is part of the apex. This image captures for you the CT scan image at the level of the eye. It's an axial CT scan image at the level of the eye, showing you a number of structures, but first also appreciating the protrusion of the eyes beyond the orbital socket to increase the size of the visual field. Also appreciating the fact that the medial walls of the orbit are almost parallel to each other. That and that one labeled 5. Also appreciating that the lateral walls of the orbit are making almost 90 degrees to each other if you extend the lines right and left. So this one and that one. Also appreciate that the orbits are conical with the apex here, posterior labeled 2, and the base in this side. At the orbital apex, there are a number of structures that we find. So several neurovascular structures pass through the orbital apex, and we'll be talking about them as we look at the foramina in the orbit. Having talked about the apex and the margin, we can now talk about the orbital roof. So the orbital roof is formed mainly by the orbital plates of the frontal bone, which is the one I'm pointing at this point. However, we also have the lesser wing of the sphenoid bone, which is this one here. So this is the lesser wing of the sphenoid bone. Usually the lesser wing of the sphenoid bone has 2 roots. There's that root, and that's the lesser wing of the sphenoid bone. So those 2 bones form the roof of the orbit. Remember, the main one is orbital plate of the frontal bone. Generally, the orbital roof separates the orbital contents from the contents of the anterior cranial fossa. This particular image captures for us that very well. So this is the orbit, this is the orbital roof, in particular the orbital plate of the frontal bone, and this is the anterior cranial fossa, which houses mainly the frontal lobe of the brain. And maybe around that point, we also have the olfactory pathways, but the ones directly above the orbits are the frontal lobes of the brain. A bit anterior, the roof of the orbit is interrupted with the frontal air sinuses. These are the frontal air sinuses. They are anterior and slightly medial, so the roof has paranasal sinuses. Again, coming a bit anterior, and this time laterally, the roof is grooved by the lacrimal gland, and that groove is what we call the lacrimal fossa, found somewhere around there. So this is the location of the lacrimal fossa, the impression of the lacrimal gland. The optic canal is at that point, and as I've already told you, it lies between the two roots of the lesser wing of the sphenoid bone. So that's the orbital roof. We can now talk about the medial wall of the orbit. This is the medial wall of the orbit. So we can see a number of bones there, but the main bone is that one, the orbital plate of the ethmoid bone. This is a very thin bone. It's termed the lamina papyracea. Very thin bone, paper thin actually. And this bone separates the orbit from the ethmoidal air sinuses. This image shows you that. So this is the lamina papyracea, very thin bone, or that one, lamina papyracea. And these are the ethmoidal air sinuses. Do not confuse that with the nasal cavity, which is this one. This also shows you lamina papyracea, labeled 5, medial wall of the orbit, separating the orbit from the ethmoidal air sinuses. Do not confuse the nasal airway, which is that and that. That's the nasal septum. Apart from the lamina papyracea, we also have 3 other bones that contribute to the medial orbital wall. So we have the frontal process of the maxilla anteriorly there. We have the lacrimal bone behind it. And we have the body of sphenoid posterior to the lamina papyracea. So this is the body of sphenoid from which we have the 2 roots of the lesser wing going to the roof. The fossa for the nasolacrimal sac is found here. And this fossa of the nasolacrimal sac is bounded by 2 ridges, which we call the lacrimal crest. The anterior lacrimal crest is a crest on the frontal process of the maxilla. The posterior lacrimal crest is a crest on the lacrimal bone itself. The depression between the 2 is where you find the nasolacrimal sac, or you can just call the lacrimal sac. It's the pathway from which that lacrimal sac we have now continuation into the nasolacrimal duct. And so that's why it's sometimes called the nasolacrimal sac. This image also captures for you that this is the crest on the lacrimal bone, so the posterior lacrimal crest, and this is the anterior lacrimal crest. The depression between the 2 is the fossa of the nasolacrimal sac. So those are medial bones in the medial wall. We can now look at the bones on the floor of the orbit. The floor of the orbit is this one. The floor of the orbit is formed mainly by the orbital plate of the maxilla bone, which is the one pointed here. However, anteriorly and perhaps anterolaterally, the floor is also formed by the zygomatic bone, that particular region there. Usually, the orbital plate of the maxilla is also thin, and it's the one that separates the orbital content from the maxillary air sinus that is just beneath. This image captures for you that this is the orbit, this is the maxillary air sinus, and so this one here is the orbital floor. There's a groove that separates the orbital floor from the lateral wall. So this is the inferior orbital fissure, which separates the floor from the lateral wall of the orbit. Now, this bone here is usually also thin. And so when there is pressure in the orbit, this bone can actually be fractured. We call this one blood fractures. When there's a blood fracture, it's characterized by entrapment of soft tissues within the floor of the orbit. Could be muscles, could be nerves, could be blood vessels. And as a result of this, there'll be restricted movement of the eye because muscles have been trapped. There's also inward movement of the eye, and that's what we call enophthalmos. The eyes retract, go back. And because now the visual axis may not be parallel, the right and the left visual axis may not be parallel, somebody may have double vision, what we call diplopia. This image shows you an example of a case of blood fracture where the floor of the orbit has been fractured, and so things have prolapsed down through the fracture site. This is even extreme where a lot of soft tissues have gone and even filled in the maxillary air sinus. The orbital floor, as I've already mentioned, is separated from the lateral wall by the infraorbital fissure. This is the inferior orbital fissure, separating the floor from the lateral wall. Now we can talk about that very lateral wall. Lateral wall of the orbit is formed by two major bones. We have the greater wing of the sphenoid bone, which is the one I'm pointing at right now. And we have the zygomatic bone, in fact, the frontal process of the zygomatic bone, which is this region here. So as you can see, those are the two major bones in the lateral wall. There's a fissure separating them, as you can see there. When you take this lateral wall posteriorly, you will note that the lateral wall is separated from the roof via the superior orbital fissure. The lateral wall is considered the thickest wall of the orbit. Out of all the four, this is the thickest wall of the orbit, and so therefore the strongest perhaps. And we can even appreciate that from this particular image. Look at the thickness of that zygomatic bone and compare with this one here. And also this in the middle wall and in the roof, in the floor, sorry. The lateral wall of the orbit separates the orbital content from two important spaces. And this particular axial image shows us these spaces very well. So anteriorly, there's this space here. We call that region the infratemporal fossa. So there'll be temporal extending to the infratemporal fossa there. And posteriorly, we have the middle cranial fossa. So infratemporal fossa is lateral and on the anterior aspect. The middle cranial fossa is lateral, but on the posterior aspect of the orbit. These are the lateral important relations of the orbit. Remember, this fossa has contents within them. We have contents of the middle cranial fossa, in particular the temporal lobes of the brain are the ones that rest here. And here in the infratemporal fossa, there are a number of structures. We'll talk about infratemporal fossa quite later. Great, so that summarizes the story of the orbital walls. We now want to talk about the orbital fissures and orbital foramina. We can start with the optic canal, which is this one here. The optic canal lies between the two roots of the lesser wing of the sphenoid bone, and it connects the orbit to the middle cranial fossa. So beyond this, it will take you to the middle cranial fossa. This canal has the following. We have the optic nerve and its meningeal sheath. So usually the optic nerve is covered by the meninges, including dura mater itself, and so it also has subarachnoid space within it. So the meningeal sheath of the optic nerve, together the optic nerve, passes through here. This image captures for you that very well. So this is the optic nerve itself. This hyperintense signal, hyperintense here means that it's bright, using this MRI image. So this hyperintense signal represents fluid around the optic nerve, telling you that this is CSF, which means that there's some subarachnoid space going through. So that's the meningeal sheath that surrounds the optic nerve. Of course, this is already inside the orbit, but now perhaps this is where it's crossing the optic canal. Apart from that, we have the ophthalmic artery, which is a branch of the internal carotid artery to the orbit. Around the optic canal, there's a common tendinous ring that marks the attachment of the four recti muscles. We are going to talk about them: the superior rectors, inferior rectors, medial rectors, and lateral rectors. They originate around the opening of the optic canal. In fact, they enclose the optic canal. So this image shows you the common tendinous ring marking the origin of the four recti muscles. So this ring here encircles the optic canal. As you can see, it also encircles some parts of the superior orbital fissure. And within that tendinous ring, there are a number of structures that pass through. We'll be talking about them shortly. We've talked about the optic canal. We can now talk about the superior orbital fissure. This is the gap here between the lesser wing of sphenoid and the greater wing of sphenoid. That's what we call the superior orbital fissure. It connects the cranial cavity with the orbit. So this also connects the cranial cavity with the orbit, and in particular, largely, again, the middle cranial fossa with the orbit. The following structures pass through the superior orbital fissure. We have the third cranial nerve, which we call the oculomotor nerve. It has two divisions. They both pass through there, superior and inferior division. We have the trochlear nerve, which is the fourth cranial nerve. It also passes through there. We have the ophthalmic nerve. In particular, they'll have already branched. So the various branches of the ophthalmic nerve, mesociliary nerve, lacrimal nerve, and frontal nerves will pass through the superior orbital fissure. The sixth cranial nerve is the abducens nerve, which also passes through here. And lastly, we have the ophthalmic veins. There are two, superior and inferior ophthalmic veins. They pass through here. Other than that, we also have the inferior orbital fissure. This is the inferior orbital fissure. It's an extensive cleft in the floor of the orbit, actually, bounded by a number of bones, but these bones separate or mark the separation between the lateral wall and the floor of the orbit. The inferior orbital fissure connects the pterygopalatine and infratemporal fossae to the orbit. So there's a space called the pterygopalatine fossa. There's a space called the infratemporal fossa. These two fossae communicate with the orbit through the inferior orbital fissure. The following structures will pass through the inferior orbital fissure. So we're looking at the ones below here. We have the infraorbital and zygomatic branches of the maxillary nerve. So by this time, maxillary nerve has already divided. Maxillary nerve is the second division of trigeminal. It goes through what we call foramen rotundum, then divides into a number of branches. And so these infraorbital and zygomatic branches are the branches which will pass through the inferior orbital fissure. They are accompanied with some blood vessels. The blood vessels which accompany them are also running within this fissure. We also have the orbital branches from the pterygopalatine ganglion. The pterygopalatine ganglion is a parasympathetic ganglion, marking the synapse of the preganglionic fibers which came from facial nerve eventually. If you remember that story, from the facial nerve, we have the greater petrosal nerve, which joins with the deep petrosal nerve to form the Vidian nerve, or the nerve of the pterygoid canal. The fibers synapse, or rather join maxillary nerve, then synapse within the pterygopalatine ganglion. So postganglionic fibers from this ganglion pass through the inferior orbital fissure to enter the orbit. The connection between the inferior ophthalmic vein and the pterygoid plexus of veins is also seen to pass through here. Now understand that the inferior ophthalmic vein takes blood back to the cranial cavity through the superior orbital fissure, but there's an anastomotic vessel that passes through the inferior orbital fissure to reach the pterygoid plexus of veins. And that's why you're seeing inferior ophthalmic vein in both the superior orbital fissure as well as the inferior orbital fissure here. All right, so that was the inferior orbital fissure. We also have two other categories of foramina to talk about. We can begin with the ethmoidal foramina. We have two, usually, sometimes three, the anterior and the posterior ethmoidal foramen, located very near the frontoethmoidal suture. This is the frontoethmoidal suture. They transmit the neurovascular structures which have the same names. So we have the anterior ethmoidal nerve, artery, and vein passing through those foramina to enter into the anterior cranial fossa, as well as to go to the ethmoidal sinuses and to the nasal cavity. Then we have the zygomatic foramina. Again, there are two. We have the zygomatico-temporal foramen and the zygomatico-facial foramen. These are also minute, and they traverse the cutaneous branches of the maxillary nerve, which have the same names: zygomatico-temporal nerve and zygomatico-facial nerve. These ones go to supply the skin. These images show you those branches of maxillary nerve, and also captures for you that maxillary nerve has many other branches, but we've already talked about the infraorbital within the inferior orbital fissure. We've also now talked about the zygomatico-temporal branch and the zygomaticofacial branch. These are branches of the zygomatic nerve, which is a branch of maxillary. Great. So I want us to now talk about the anatomy of the tendinous ring of the orbit. Consider that I told you that the tendinous ring is found around the orbital apex. So the tendinous ring is the fibrous ring that surrounds the optic canal entirely, but also surrounds the superior orbital fissure partially. You can see here it encloses the whole of the optic canal, but it encircles part of the superior orbital fissure, the lower part of the superior orbital fissure. So this is the region of the orbital apex. Remember that one. This fibrous ring forms point of origin of the four recti muscles: superior rectus, medial rectus, inferior rectus, and lateral rectus muscle. So they have a common tendinous origin. This image shows you again that tendinous origin towards the apex of the orbit with inferior rectus, perhaps medial rectus, this lateral rectus, and superior rectus. This image also captures for you that anatomy. So we'll expect the superior rectus, the the medial rectus here, the inferior rectus, and the lateral rectus to originate within the ring. But from this image, you can also appreciate that even the other extraocular muscles may partly also be attached to the tendinous ring. Of importance to note is that the tendinous ring encircles the whole of the optic canal and the lower part of the superior orbital fissure. The inferior orbital fissure is not encircled by the ring, and the upper parts of the superior orbital fissure is also not encircled by the tendinous ring. With that in mind, so which structures are within the ring? There'll be contents of the optic canal, which means the optic nerve and the ophthalmic artery. There'll also be some contents of the superior orbital fissure. In particular, we can talk about the oculomotor nerve, both superior division as well as inferior division. We can also talk about the nasociliary branch of the ophthalmic division of trigeminal nerve. And we can talk about the abducens nerve, which is the sixth cranial nerve. So those ones are within the ring. But there are some structures which are outside the ring. In particular, we can start the contents of the inferior orbital fissure that we've already mentioned. So the inferior ophthalmic vein, we talked about the infraorbital nerve and artery, and we talked about the zygomatic nerve, which is a branch of maxillary. Those ones are within the inferior orbital fissures, hence not within the ring. Lastly, there's some other contents of the superior orbital fissure, which are also not part of the ring. We can mention them again. So we have the trochlear nerve there. We have the lacrimal branch of the ophthalmic nerve, the frontal branch of the ophthalmic nerve, and there's some vessels also, which are also not within the ring. Okay, so this is just a repetition of what I've already told you. You can look at it slowly and try to appreciate the anatomy of the orbital apex and how the tendinous ring relates to this region of the orbital apex, so that you're able to capture which structures are within the ring and which structures are outside the ring. Fourth objective will now be to talk about the fascial layers of the orbit. We will also talk about the orbital fat. Maybe before we talk about these layers, it's important to mention that the fascial layers of the orbit is really complex. And we'll just try to go slowly onto it and try to make sense out of it, actually. These fascial layers of the orbit have a number of functions. They provide structural support to the eyeball itself. They also limit movements of the eyeball, extreme movements of the eyeball, let's say so that you don't have the eyes doing some funny 360 degrees, perhaps like that of a chameleon. I didn't say that chameleon does 360, but at least you know that it moves a lot. Well, the fascial layers of the orbit also put into compartments the fat of the orbit, orbital fat. Some of its components are named. They include the following. So there is what we call the periorbiter. We look at it. This is what we call the orbital septum. We'll also look at it. We have what we call the Tenon's capsule, or the fascial sheath of the eyeball. We look at it. We have the check ligaments, and we have the suspensory ligaments of Lockwood. We look at all of them. There are still others that we want to look at. Let's begin with the simple one, the periorbiter. So what is periorbiter? Periorbiter is simply the periosteum of the bony orbit. You know, that connective tissue membrane that surrounds bone. So when you're in the orbit, there's still definitely periosteum that line the bones of the orbit. So we call that one the periorbiter. It therefore surrounds all the orbital contents if you think about it. There's some points to note about the periorbiter. Generally, it doesn't attach strongly onto the bones of the orbit, except at the orbital margins where it is strongly adherent, and also around sutures and foramina, and even the fissures, we can say so. So only on those regions, the periorbiter is strongly adherent. In the other places, it's not strongly adherent. And that means that it's possible that there's a potential space, therefore, between the periorbiter and the orbital bones themselves. And we'll talk about that shortly. The periorbiter is also perforated by a number of neurovascular structures throughout. You would expect that to happen if vessels and nerves need to pass through into the orbit or from the orbit to other places. Then they have to go through the periorbiter through various foramina. Now, the periorbiter is thickened around the orbital apex. So at this level, the orbital apex, the periorbiter is quite thickened. And that thickening of the periorbiter around the orbital apex is what constitutes the common tendinous ring, which is also known as the annulus of Zinn. So that common tendinous ring that we already talked about is actually a circular thickening of the periorbiter around the orbital apex. Important also to note that periorbiter merges with some things. It merges with the periosteum of the skull. Remember, that is what we call the periosteal layer of the dura mater, as opposed to the meningeal layer of the dura mater. It also merges with the optic nerve sheath. If you remember, I told you that optic nerve has a sheath of meninges. So it's covered by dura mater. So the dura mater that covers the optic nerve also merges with the periorbiter around the orbital apex. Second fascial layer is what we call the orbital septum. This, again, is not very complex. From this image, we can actually appreciate what it is. Look at this. So this is the periorbiter, which is the periosteum of the bones of the orbit. Continuing that way, then this is now the orbital septum. It's just a thin sheet of fibrous tissue, it's membranous actually, which extends from the attachment of the periorbiter at the orbital margin. And this membrane continues into the eyelids, both superior as well as inferior eyelids. Now, the eyelids usually have fibrous material within them, which you call the tarsal plate. So this orbital septum goes up to this tarsal plate, superior and inferior tarsal plate. Some points to note is that the orbital septum separates the intraorbital fat from the orbicularis oculi muscle and the fat within the eyelid. Maybe this is a better image to illustrate that. So if this is the orbital septum, extending from the margin of the orbit, an extension of the periorbiter there, into the tarsal plate. So this is the superior tarsal plate, this is the inferior tarsal plate. This orbital septum separates the fat within the orbit, intraorbital fat, from the fat within the eyelids, but also from the orbicularis oculi muscle as well. Because of this separation, we note that the orbital septum is clinically important. It helps in limiting spread of infections between the two spaces, and you are more worried about infection coming from outside going into the orbit. So we call this the preseptal space, and we call this the postseptal space. Remember, the postseptal space is actually the orbital cavity proper. There are a number of neurovascular structures that will pass through the orbital septum. In particular, these neurovascular structures are going to supply the scalp and the face. So they'll pass through the orbital septum as they go to supply the structures in the scalp and face. So this image also captures for you the orbital septum anatomy. This is the orbital septum there, extending from the margin up to the tarsal plate. So this is the superior tarsal plate, which is usually bigger than the inferior tarsal plate. And so in this image, this is the orbital septum there. The third fascial layer to talk about is the Tenon's capsule. The Tenon's capsule is thin. It's a fascial sheet that actually surrounds the eyeball itself. It extends from the attachment of the optic nerve to the eyeball all the way to the corneoscleral junction, what we call the limbus. The corneoscleral junction is the junction between the cornea in front, which is this part, and the sclera behind, which is this part. Maybe let me say that the corneoscleral layer of the eye is the outermost layer of the eyeball, consisting of fibrous connective tissue. So in front, it is characterized by very fine organization that forms a transparency for passage of light, and that's what we call the cornea. And then posteriorly, it's an opaque whitish structure, which we call the sclera. The junction between the two is what we call the corneoscleral junction or the limbus. So that's the point of attachment of the Tenon's capsule. This fascia, Tenon's capsule, is also known as the fascia bulbi or the bulbar sheath, or basically the fascial sheath of the eyeball. It is not very strongly adherent to the eyeball itself, and for that reason, there is also a space consisting of loose connective tissue between the membrane itself and the sclera. And that space, what we call the subtenon space. Now, points to note is that this fascia provides a socket which separates the globe from the surrounding fat. Because of that, it allows free movement of the eye. So even though the fat is not moving, the eye can move within that particular socket. There are a number of structures that traverse the fascia, and in particular, the ciliary vessels and nerves will pass through this particular layer to supply the eyeball itself. The tendons of the extraocular muscles also pierce this particular fascia, like what you can see there, because these extraocular muscles attach on the sclera. So they have to pierce this fascia to attach to the sclera. I've already mentioned the subtenon space, which is also known as the episcleral space or periscleral space. This space is a potential space for administering anesthetic drugs that are supposed to anesthetize the globe. So if the injection is done into this space, it can spread easily. And that means that it can spread around the whole globe easily to anesthetize it. Posteriorly, that fascia merges with the sheath of the optic nerve. So remember, the sheath of the optic nerve was merging with the periorbita much posteriorly, but even here, it also merges with the Tenon's capsule. So that was the third fascial layer. We can talk about the fourth fascial layer, the check ligaments. However, before talking about the check ligament, there's something that is important to understand. I've mentioned to you that extraocular muscles pierce the Tenon's capsule to attach to the sclera. As the muscles pierce the Tenon's capsule to attach the sclera, the fascia, the capsule, sends some extension into the muscle. And those extensions of the capsule into the muscle, like this one, is what we call the muscular sheaths or muscular fascia. So the muscular fascia that surround the extraocular musculature are generally extensions of the fascia of the eyeball into the muscles. There are some fascial sheaths or muscular sheaths which are thicker, and there are some which are insignificant. Now, what a check ligament? A check ligament is an expansion from the muscular fascia to the surrounding bones. So the muscular fascia has some expansions to the surrounding bones. We call these ones the check ligaments. Not all of them are important, quite. However, the one for the medial rectus and the lateral rectus are very important. So see here, this is the medial rectus muscle piercing the Tenon's capsule at this point to enter the eye, to attach to the sclera. This is the muscular sheath around the medial rectus as an extension of the Tenon's capsule or the bulbar fascia. So the whole of that is a muscular sheath. Now we can see the expansion of the muscular sheath from the medial rectus to the surrounding bone. So this is a check ligament. And because related to the medial rectus, we call them medial check ligaments. We have a similar arrangement for the lateral rectus, which we call the lateral check ligament. So that's the concept of the check ligaments. They're just extensions or expansions of the muscular fascia of the muscles to the surrounding bone. The check ligaments related to the medial and the lateral rectus muscle are the strongest and perhaps the most important ones. Their major aim is to limit excessive movements of the eye. So for example, this eye cannot adduct so strongly because it will be limited by the lateral check ligament. And the eye again cannot abduct so extremely because it will be limited by the medial check ligament. Okay, this other image shows us the check ligaments. So that's the medial check ligament, and that's the lateral check ligament. Told you the limit adduction and abduction of the eye. The other check ligaments, as I've mentioned, are not so significant, and so we don't really have to talk about them. All right, the other ligament to talk about is the suspensory ligament. The suspensory ligament is actually the thickened part of the bulbar fascia inferiorly. It's a thickening of the bulbar fascia inferiorly. So this, the bulbar fascia, it's thicker inferiorly compared to superiorly. So this inferior thickening is what we call the suspensory ligament. There's some things to note about the suspensory ligament though. Remember that the fascial sheaths, the muscular fascia, were also extensions of the fascia bulbar. And so we have that extension around the medial rectus, and you have that expansion around the lateral rectus. Then the extension from the muscular fascia to the bone is what we call the check ligaments. So there's a lateral check ligament, there's a medial check ligament. That means that the check ligament and this inferior thickening of the bulbar fascia are actually continuous. Coming down, there's two muscles below, the inferior oblique muscle and the inferior rectus muscle. Again, their muscular fascia blend with the thickening of the bulbar fascia. So the whole thing, that thickening of the bulbar fascia inferiorly, is attached or is blended with the medial and the lateral check ligaments, and also blends with the muscular fascia around the inferior oblique and inferior rectus. The whole thing constitutes still the suspensory ligament. This suspensory ligament is very important. Look at that image there. We see it there. The suspensory ligament is quite important because even if you are to remove the maxilla down here, it can still suspend the globe. So it's clinically important that it maintains the position of the eye, even if the maxilla is removed. The globe will just rest on the suspensory ligament. And actually that's why it's called the suspensory ligament. So the globe doesn't have to make physical contact with the floor of the orbit, actually. That's why we're saying that it's suspended above. It's also called the ligament of Lockwood, as I'd mentioned perhaps earlier. So that summarizes the most important ligaments of the, or rather fascial systems of the orbit. Now we can talk about the orbit of fat. Orbit of fat occupy the spaces between the main structures of the orbit. So there's some that are within here, some that are outside the cone of the musculature, some within the cone of the musculature. they are in most compartments. So most of the fat is around the optic nerve, which means within the cone of the musculature. The importance of this fat is to help stabilize the position of the eye so that you don't have a lot of oscillations of the eyeball. There are a lot of septa that go through the fat though, like this one. They just traverse the fat, and so putting the fat into even more tiny compartments. If there was to be a pathology that causes increase in the volume of intraorbital fat, such pathology will force the eyeball to be pushed out a bit, and that's what we call exophthalmos. This condition is commonly seen in people with hyperthyroidism. So there is a increased volume of the orbital fat, and that means that they're now competing for space. And so what happens is that the globe itself will be pushed forwards. And so a big part of it will be protruding out of the orbital sockets. That's what we call exophthalmos. Now we can talk about the extraocular muscles and eye movements. Perhaps before we talk about the extraocular muscles, it is important to understand the axis through which the eye moves. We can describe the eye as being able to move on three important axes. Just imagine your eye. There are three important axes of movement of the eye. The first one, let's describe this one, the transverse axis, or what is written here as the y-axis. So the transverse axis is through like that, right to left. On this axis, the eye can go up and down. For you to understand the movement of the eye, understand that it's the position of the pupil that changes. So if you have a ball, and the eyeball is an example of a ball, and you have a transverse axis through that ball, can move up and down. It can swing up and down around that axis. So the transverse axis allows for elevation and depression. Elevation is when the pupil faces up, and depression is when the pupil faces down. Perhaps I can demonstrate for you if you look at my eyes. So this is elevation, this is depression of the eyes. Then we have this vertical axis. So the vertical axis is vertical through each eye. The vertical axis allows for adduction and abduction movements of the eye. So if you focus on my right eye, that is adduction, it faces medially, and that is abduction, it faces laterally. Finally, we have the anteroposterior axis. The anteroposterior axis allows rotation of the eye. Medial rotation, as this arrow shows, is what we call intorsion. And lateral rotation, as this arrow shows, is what we call extorsion. So there is intorsion and extorsion of the eye. With that understanding, we can now look at the extraocular musculature. We have a total of 7 skeletal muscles within the orbit. Out of these 7, 6 of them actually move the eye. One doesn't move the eye, it moves the upper eyelid. I want us to talk about these 6 muscles. Let's start with the one that moves the upper eyelid. We call it levator palpebral superioris. This muscle rises from the upper end of the tendinous ring, and it attaches onto the upper eyelid. At the point of insertion of the muscle into the upper eyelid, there's a smooth muscle component of it, which we call the superior tarsal muscle, otherwise known as the smooth muscle of Muller. So that means that there will be a skeletal component of this muscle and a smooth component of this muscle. This image captures for us that. So the levator palpebris superioris comes, then there's a smooth component of it. As we can see, it goes to the superior tarsal plate, and that's why it's called the superior tarsal muscle. There's some slips of the levator palpebris superioris that will go to the skin of the upper eyelid and usually blending with the orbicularis oculi muscle. And there's some part that will go to the fornix of the conjunctiva. The fornix is a junction between the conjunctiva that lines the eyelid, the palpebral conjunctiva, and the conjunctiva that lines the eyeball, the bulbar conjunctiva. So this junction there is called the fornix of the conjunctiva, and some slips attached there. The levator palpebris superioris is innervated by the superior division of the oculomotor nerve. This is the oculomotor nerve. It has two divisions, superior and inferior divisions. So the superior division is the one that goes to the levator palpebris superioris. The oculomotor nerve is a third cranial nerve. That part of oculomotor nerve supplying the levator palpebris superioris particularly target the skeletal components of the muscle. The smooth muscle components rely on postganglionic sympathetic fibers because now it's smooth muscle. It has to be autonomic innervation. So it's sympathetic nerves that supply the smooth component. The main action of this muscle is to elevate the upper eyelid, as the name suggests. Now, sometimes it may fail to do that because of perhaps distortion or interruption of the sympathetic innervation going to the head in a condition known as Horner syndrome. So in this condition known as Horner syndrome, there is disruption of the sympathetic supply to the head region. As a result, the structures in the head region that rely on sympathetic innervation are affected. The levator palpebris superioris is not the only structure, but it's one of the structures affected. So for it, because the smooth muscle component of the muscle will be paralyzed, it means that it can't act. The upper eyelid will therefore not elevate fully. So the upper eyelid will be dropping partially. Dropping of the upper eyelid is what we call ptosis, the P silent. So this image shows you someone with the ptosis of the left eye. As you can see, the upper eyelid is drooping. You can see the fold is not as marked as this one. And the margin of the upper eyelid is a bit down. So it's a partial ptosis. If you are to paralyze the levator palpebris superioris completely, then you'll perhaps get a complete ptosis. It closes almost entirely. The other category of muscles talk about are the medial and the lateral recti muscles. So this is the lateral rectus muscle. The medial rectus will look like that, except now on the medial aspect. Generally, the recti muscles, all the four, arise from the common tendinous ring and they insert onto the sclera. Now, they insert onto the sclera just behind the limbus, a few millimeters just behind the limbus. Usually not, it's within 1 centimeter. So some will be about 5 millimeters, some 7 millimeters from the limbus. They insert onto the sclera. And that applies for all the recti muscles, all of them. So they touch much anteriorly. That's the point. Their attachment is much anterior into the globe. Okay, this shows you that attachment much anterior on the globe. So whether superior or lateral or inferior or medial, that concept remains the same. And this is also showing you that. So this is the medial rectus. So this is the lateral rectus going there. And these are medial rectors there. The medial rectus is slightly shorter compared to the lateral rectus, as you can see there. Now, lateral rectus muscle, this one, is innervated by the abducens nerve. This is the sixth cranial nerve. And the contraction of the lateral rectus muscle will cause this pupil to move that way. And we call that abduction. And that is why the nerve is also called abducens. The medial rectus is this one. The contraction of the medial rectus will cause this pupil to move that way. That's what we call adduction. Medial rectus is supplied by the inferior division of the oculomotor nerve. So this shows you still medial rectus, and that's lateral rectus. So if the lateral rectus contracts, this pupil moves that way. Because remember, it pulls away from here towards the apex. If the medial rectus contracts, this pupil moves that way. That's what we call adduction. This image still show you that. So medial rectus acting, the pupil moves medially, adduction. This one, lateral rectus contracting, the pupil moves laterally, abduction. How about if both the right and the left medial rectus contract? What will happen? The pupils will move toward the center, and that is what we call ocular convergence. So the medial rectors are the ones responsible for ocular convergence. This is particularly possible when you want to see something at the root of your nose, something with a very short focal distance. Okay, now we can talk about the superior and inferior recti muscles. Just like the others, they also still arise from the common tendinous ring, and they'll attach into the sclera just behind the limbus. The nerve supply of the superior and inferior recti are still oculomotor nerve, but now various divisions. So superior rectus by the superior division of oculomotor nerve, and inferior rectus by the inferior division of oculomotor nerve. This shows you the superior division of oculomotor, the slip to superior rectus. This shows you the inferior division of oculomotor, slip to inferior rectus. The axis of pull of the recti is something to take note of if you're going to understand the mechanism of action of the superior and inferior recti. When you look at the axis of pull of the superior and inferior recti, it is not parallel to the visual axis. This is a visual axis. So that's basically the main equator or the axis of the eye. But this is the axis of pull of the superior and inferior rectus. It's some 23 degrees or about 25 degrees there. That need to be taken into account if you're going to understand the mechanism of action of superior rectus. Now, let's begin the superior rectus. What are the actions then? If it contracts, it will make the pupil to go up. And that will be especially true if this pupil was already slightly abducted. Then now superior rectus contracts, it will elevate the pupil. If it is working this position, perhaps if it is working together with the inferior oblique simultaneously, the inferior oblique we are yet to talk about, but this one here. So if this inferior oblique is acting and superior rectus also acting, they will both elevate the eye. So this shows you the superior rectus. You can imagine if it's pulling that way, it will definitely cause elevation. Nothing strong, nothing hard about that. The superior rectus also adducts the eye from a neutral position, and it is important to understand that based on the orientation. Remember, there's some degrees so that the axis of the eye and the axis of pull of the superior rectus and inferior rectus is not parallel. So if they're inserting somewhere in front, the superior rectus contracts, even inferior rectus contracts, the pupil will go medially because the axis of pull of the recti is not parallel to the axis of vision of the eye. So contraction of the superior and inferior recti will cause the eye to go medially, and that is adduction. Both superior and inferior recti adduct the eye because of that mechanism that I've just explained. This is the axis of adduction, abduction, the vertical axis. Now, if the eye is slightly medially rotated and superior rectus contracts, then something fantastic will happen. It will cause intorsion. Now look at this. So this neutral position, if the eye is abducted and superior rectus contracts, it will cause elevation. I think that one is straightforward. If the eye is already adducted and the superior rectus contracts, it will cause the upper part to go much backwards and the lower parts will therefore go much forwards, and that is basically rotation. And that rotation is internal rotation, what we call intorsion. So superior rectus causes intorsion. Now in this neutral position, if the superior rectus contracts at this point, the pupil will move medially. And so the posterior pole will go laterally. It's really like the steering wheel of a car. And that is now adduction. Both superior and inferior rectus cause adduction. Okay, that is superior rectus. So we mentioned a number of things that will also apply to inferior rectus. There is the inferior rectus. Its contraction will pull the pupil down. So that is depression. It will also cause adduction from the same mechanism that I've already explained. And it also causes external rotation. Now, if you understood the internal rotation, you understand that if this eye is adducted and the inferior rectus, the other one contracts, it will pull the lower surface of the eyeball posteriorly, the upper surface of the eyeball will go anteriorly, and that is external rotation around the anterior-posterior axis of the eye. This illustrates for you the action of the inferior rectus and the actions of the superior rectus tail. All right, now we can talk about the two obliques. We'll start with the superior oblique, then inferior oblique. The superior oblique arises from the superomedial corner of the tendinous ring. So usually on the superomedial aspect of the tendinous ring, it has an acute turn anteriorly, and the point of turn is what we call the trochlea. It's actually a pulley for its tendon with a synovial shape actually. And so that makes the tendon turn less than 90 degrees and go backwards to the eyeball to insert on the superolateral aspect. Now remember, it's superior and lateral. Superolateral aspect of the posterior sclera, which means that it inserts behind the equator of the globe. Again, very important to remember that part. It inserts behind the equator, behind the vertical axis of the globe. That is why if it pulls, it will pull the posterior part medially, but then the anterior part will go laterally. And so it will actually cause an abduction movement rather than adduction. So this still shows you the superior oblique muscle with its trochlea, the pulley, then its insertion on this posterior superior lateral aspect of the sclera. The superior oblique is innervated by the fourth cranial nerve, which is the trochlear nerve. The effective axis of pull is therefore this axis here. This axis is about 51 degrees from the visual axis. So if you compare this with that, about 51 degrees here. I told you this angle was acute. So what are the actions of superior oblique with that understanding? First, it is easy now to understand that both the superior oblique and inferior oblique will actually cause abduction of the eye because they pull the posterior aspects medially, and so the anterior aspects will go laterally. This shows you that concept. This is the neutral axis, the visual axis, the axis of the globe. So this muscle pull this posterior part medially, this part will go laterally, so that is abduction. It will also depress the eye, and depression is better illustrated on this image. If the eye is already adducted and superior oblique contracts, it will pull the posterior part of the globe forwards, and so the pupil will go down. That is depression. If, however, the globe is already abducted and superior oblique contracts, it will pull the posterior aspect of the globe medially, the lower part will go laterally, and that is now rotation. Particularly, that is internal rotation. So these are the actions of superior oblique. Remember that the superior oblique, the green one, so its contraction should make you understand that it will cause internal rotation. The upper part will go medially, and so this lower part goes laterally, and that is internal rotation. Or intorsion. These are the images illustrate for you the same concept that we have already clarified. Last but not least, the inferior oblique muscle. It also arises from, okay, it doesn't arise from the orbital apex like the other muscles. Important to note. This muscle arises from the inferomedial orbital margin, this point. It doesn't arise posteriorly, it arises anteriorly. Then now takes an inferior posterior turn to insert onto the inferolateral aspect of the posterior sclera, again, posterior sclera. And that is why, again, its contractions will therefore pull the posterior part medially, and so the anterior part, the pupil go laterally. That's why it will cause abduction, just like superior oblique. The inferior oblique is innervated by the inferior division of the oculomotor nerve. The effective axis of pull is similar to that one of the superior oblique. So its actions will be to elevate the eye. It is pulling the posterior part forwards from the inferior aspect, so it will elevate the pupil. It also causes external rotation because it's pulling the lower part medially, so the upper part goes laterally. That is external rotation, as this image illustrates. So this is the action of the inferior oblique. If this inferior oblique pulls like this, so this part goes that way, and this part will now go that way. That's lateral rotation or extorsion. It will also abduct the eye from the mechanisms I've already explained to you, that they pull the posterior parts medially, the anterior part will go laterally. That will apply for both superior and inferior oblique muscle. So those are the extraocular musculature. This image here is a nice image to help you remember the actions of each of the extraocular muscles. You can just take time to go through and try to understand. It's a nice summary of the actions of the extraocular musculature, and I'm referring to the 6 that move the eye. As we finish the extraocular musculature, we can now talk about the orbital spaces. So there are a number of potential spaces within the orbit, and they have different names. I told you that the periorbita is not adherent to the bones, and so there's space there. Remember, periorbita is periosteum. So the space between the bone and the periorbita is called the subperiosteal space. The extraocular musculature form a cone between the globe and the orbital apex. And so the space external to the extraocular musculature is known as the extracorneal space. And the space internal to the cone is known as the intracorneal space. So this is the intracorneal space. The intracorneal space contains a number of things. Of course, we expect fat to be there, but apart from fat, we also expect the optic nerve there. We expect the two divisions of oculomotor nerve, the ciliary ganglion, which is from the inferior division of oculomotor. Mesociliary nerve, which is a branch of the ophthalmic nerve, is also within this particular corneal space. Then abducens nerve, which goes to the lateral rectus, is also a content of this space. The ophthalmic artery is a content of the space as well. How about the extracorneal space? The extracorneal space is within here. The extracorneal space houses fat. It houses the lacrimal gland, which is in the superior lateral orbital margin. It houses the ophthalmic artery branches. So the branches of the ophthalmic artery will be in this space. The ophthalmic artery itself is here, but its branches are within the extracorneal space. The ophthalmic veins are usually within the extracorneal space. The infraorbital vessels, remember they are running within the infraorbital fissure. They are within the extracorneal space. We have the trochlear nerve, fourth cranial nerve in the space. The frontal and lacrimal branches of the ophthalmic division of trigeminal are in this space. Branches of the mesociliary nerve are also in this space. Remember, the mesociliary nerve itself is in the intracorneal space, but its branches are in the extracorneal space. And we have branches of the maxillary nerve, which are in the orbit, the infraorbital nerve and the zygomatic nerve, which are found within the in the infraorbital fissure. So they're also extracorneal. The other space to talk about is the subtenon space. The subtenon space is also known as the the bulbar bursa. Remember, that's the one that enables the eye to move independent of the fat. We have the subarachnoid space. The subarachnoid space will be the space around the optic nerve itself, because remember, optic nerve is covered by dura mater, arachnoid matter, and pia mater, and so there is a subarachnoid space there which contains CSF. Okay, now we can finish with the orbital neurovascular structures. We can start with the ophthalmic artery. Ophthalmic artery is the main artery that supplies the intraorbital structures, but we also have the inferior orbital artery or the infraorbital artery, which is a branch of the maxillary artery, also supplying some parts, some structures, but the main artery is the ophthalmic artery. Ophthalmic artery is a branch of the internal carotid artery. It enters through the optic canal, gives a number of branches, and we can just name them here. So this is the lacrimal branch. We also have the supraorbital branch. We have the supratrochlear branch. We have the dorsal nasal branch there. We have the medial palpebral branch. The medial palpebral branch is usually anastomosed with the lateral palpebral branch on the eyelid. The palpebral is the eyelid. We have the ethmoidal branches, so the anterior ethmoidal branch, posterior ethmoidal branch. And we have the ciliary branches. The ciliary branches can be classified as medial and lateral. We can also classify the ciliary branches are short and long. The long ones will go through the eyeball to go much anterior, and the short ones remain largely posterior here. Anyway, they're ciliary branches. Importantly, the very first branch of the ophthalmic artery goes into the optic nerve and supplies the retina. We call that one the central retinal artery. It's the very first branch of the ophthalmic artery. Also important to note is that there are a number of anastomoses that the branches of the ophthalmic artery make with other arteries. So there's some anastomosis on the face, like supratrochlear, supraorbital will anastomose the scalp. There's anastomosis between the meningeal branch of the lacrimal artery and the middle meningeal artery. You can see that anastomosis there. Some anastomosis with the some arteries which are branches of the maxillary artery, you can see there. So there are several anastomosis. That means that through ophthalmic artery, we have extracranial arteries and intercranial arteries anastomosing. And in other words, the branches of external carotid and the branches of internal carotid anastomose through this region. How about the veins? So the veins that drain the orbit, largely the superior and inferior ophthalmic veins. Superior ophthalmic vein drains through the orbit, passes through the supraorbital fissure to go to the cavernous sinus. The inferior ophthalmic vein as well does the same, but the inferior ophthalmic vein has communication with the pterygoid plexus of veins. And remember, this connection through the pterygoid plexus of veins can still reach the cavernous sinus as well from our previous sessions. And so that marks point of spread of infection from the face to the cavernous sinus. How about the nerves in the orbit? We can start with the optic nerve, the second cranial nerve, optic nerve. The optic nerve comes from the retina. So it's the main sensory nerve of the retina, carrying visual impulses. That's a spatial sensation. We can describe the optic nerve as having 4 parts. The shortest part is the part passing through the sclera. We call that the intraocular part. About 1 millimeter long. The second part, which is the longest part, is the part that is passing through the intracornal compartment of the orbit. We call that the intraorbital part. The third segment is the part passing through the optic canal. We call that the intracanalicular segment. And the fourth and last part is the part that is now within the cranial cavity. We call that the intercranial segment. The right and the left optic nerve meet within the middle cranial fossa. In that region, we call the optic chiasma. Then from there, we have optic tracts taking the information all the way to the thalamus and all the way to the brain. The second part of this lecture is going to capture that very well, describing the visual pathway. The other nerve to talk about is the oculomotor nerve. Oculomotor nerve arises from the brainstem via 2 nuclei from the midbrain. We have the motor nucleus of oculomotor that carry general somatic efferent function to extraocular musculature. But we also have the Edinger-Westphal, or otherwise known as the accessory oculomotor nucleus, that carry preganglionic parasympathetic fibers, again to the eye. These preganglionic parasympathetic fibers will synapse in the ciliary ganglion. Then the postganglionics reach the eye. So remember that function is a general visceral efferent function. So oculomotor has 2 major functions, GSE to the extraocular musculature and GVE to the smooth musculature within the eye. In particular, the postganglionic parasympathetic fibers from the oculomotor are the ones which constitute the short ciliary nerves, which enter the eye. They supply or they target the iris to cause pupillary constriction. So they target the constrictor papillae muscle. They also target the ciliary body, the ciliary musculature there. The aim is to make the lens to bulge so that you can adapt for near vision. We call that accommodation. So that's the parasympathetic part. Now the GSE component, the nerves divide into 2 divisions, superior division and inferior division. The ganglion is related to the inferior division of the oculomotor nerve. So superior division of the oculomotor nerve supply the extraocular musculatures above, as you can see there, levator palpebrae superioris, superior rectus. Remember, the superior oblique is supplied by trochlear nerve. Then the inferior division supplies the rest of the muscles that are innervated by oculomotor nerve. The fourth nerve is the trochlear nerve. Trochlear nerve comes from the brainstem, again, midbrain, from the motor nucleus of trochlea, and it supplies only one muscle in the eye, that is the superior oblique muscle. Now, the trochlear nerve has some unique characteristics. It's the cranial nerve with the longest intracranial root. It is the thinnest cranial nerve as well. And we know again that is the only cranial nerve that decussates, and is the only cranial nerve that arises from the dorsal aspect of the brainstem. That's very unique about the trochlear nerve. It supplies the superior oblique muscle. Then we have the ophthalmic nerve. The ophthalmic nerve is the first division of the trigeminal nerve. This ophthalmic nerve gives a number of branches. Let's name three major ones. So the frontal nerve, the nasociliary nerve, and the lacrimal nerve. Remember, this branch of the ophthalmic of the trigeminal nerve is sensory. It's a sensory nerve. So it has general somatic afferent function. So the nucleus of the brainstem related to this nerve is the sensory nucleus of trigeminal. It doesn't have motor functions. However, the lacrimal component usually receive communicating branches, which will take parasympathetic fibers to the lacrimal gland all the way from the pterygopalatine ganglion. Remember, that is from facial nerve generally. So each of the three branches of the ophthalmic nerves has even more branches, and you can be appreciating them from here. There are several other branches. In particular, the frontal nerve is the one that eventually gives you supratrochlear and supraorbital nerve. The nasociliary nerve is the one that eventually gives you the posterior ethmoidal and the anterior ethmoidal nerves. But there are many other branches from the three, as you can appreciate from this field. So those are the major nerves, but perhaps I need to mention about the branches of maxillary nerve that are also in the orbit. The zygomatic branch of maxillary nerve is within the orbit, is the one that will eventually give you zygomaticotemporal and zygomaticofacial. But at least at this point, it's within the orbit. It's passing through the inferior orbital fissure. It's the one that receives the postganglionic parasympathetic fibers from the pterygopalatine ganglion, and is the one that communicates with the lacrimal nerve and eventually lacrimal gland receiving secretomotor fibers from the facial nerve through that route. So the secretomotor fibers do not exactly come from ophthalmic division or trigeminal, but they come from facial nerve. The infraorbital nerve is also important to note. It's also passing through the inferior orbital fissure and eventually pass through its own canal to supply the face. Great, so those are the nerves in the orbit. So that summarizes the first part of the lecture on the orbit itself. The second part of the lecture, which we are not giving here because I've already given it and I'm going to give the link, focuses on the following. It focuses on the eyeball itself and the visual pathway. And so it talks about the general anatomy of the eye, as you see it end face or even in sagittal section. And in that sagittal section, it talks about the layers of the eyeball. There are three layers of the eyeball, outer tunic, which you call tunica fibrosa, the middle tunic, which you call the vascular layer, and the inner tunic, which you call the retinal layer. So it will focus on those ones. It will also focus on the structures that bend light as light passes through the eye. We call that the refractory media of the eye. It focuses on the histological structure of the retina itself in great detail, and also talks about the different cell types within the retina. It focuses on the visual pathway, how impulses move from the retina all the way to the brain. That's the visual pathway. And also talks about the disorders associated with this visual pathway. The lecture also helps us to review the actions of the extraocular muscles, which you've done very well, but importantly also tries to tell us the lesions associated with these extraocular muscles when there is paralysis of one muscle because there is injury to one of the nerves. Then how does that affect vision, or rather the visual field? It also talks about the lacrimal apparatus, the apparatus that lead towards us producing tears. That particular lecture, I'm not giving it here because I've already given it, and that's the title of the lecture. If you just Google in YouTube, anatomy of the eye, visual pathways, and the eyeball adnexa, you're going to get it, of course, with my name. The link to that lecture is that one as well. You can type it in. This is how that lecture will come up when you click on it. It is part of the lecture series on the sensory systems that I've done. And so there's one particular one that focuses on the eye and the visual mechanisms. So because that is already given, I'm now not giving it here, but you need to listen to that as well so that you have a complete understanding of the anatomy of the orbit, the eye, and the visual system. Having assumed that you'll do that, or you've already done that, so that will be the end of this particular lecture. Then we focus just on part one, but that will be the end of it. So take time to do part two using a different link. Our next series of lectures on head and neck anatomy will be now on anatomy of the temporal bone in great detail. And we'll also talk about, in the same sitting, structure organization of the auditory and vestibular structures, the structures for hearing and structures for balance. All right, thank you very much.